Our next speaker is Dr. Tasneem Naqvi from Sinai, where she is the Associate Director of the Non-Invasive Lab. Has been involved in carotid ultrasound imaging for many years, and she's going to give us an overview of carotid ultrasound for identification of subclinical disease. Tasneem.
Thank you, Dr. Shah. Good morning, everyone. Good afternoon for me, almost. I'm actually going to start with the end of my talk, if I could, and that is that we are so impressed with this imaging modality called carotid intima media thickness that we are actually using it in our clinical practice for patients, for identifying patients who are at high risk. And I will kind of run through the evidence behind this, which has been accumulated really over the past 25 years now. You've been hearing from various speakers about the inadequacy of the conventional risk factors. You could take Framingham, you could take ProCam, about their inferiority in detecting high-risk individuals, particularly young high-risk individuals, as shown in this study, where if you took patients less than 55-year-old men and 65-year-old women, 222 of them who presented with acute MI, and then risk stratified them by Framingham risk, it would turn out that a very small minority of them would have been eligible for treatment or would have been classified as high risk a day before their acute MI. So in fact, 88% of these people would have been classified as low or intermediate risk. 82% of these women would not have qualified for drug treatment, and 59% of these men would not have qualified, which really speaks of how inadequate this conventional method of identifying risk in patients is. You're all familiar with the method of Framingham risk, which really puts in a lot of emphasis on age. And I would like to quote this article from Scott Grundy in 1999 when he talked about age as a risk factor. You are as old as your arteries, and he was really talking about bioimaging of arteries as a method that we should identify and use in our clinical practice to identify these high-risk individuals. And he pointed out to both EBCT and carotid sonography, which offer the opportunity to modify the age factor in this Framingham risk score profile as one of the ways where we could kind of better risk stratify our patients. So the goal of this SHAPE task force is to really move away from these risk factors, the list of which keeps growing every day, as you know, and focus really on the effect of these risk factors on an individual patient, be they functional methods of assessment, including brachial artery reactivity, endothelial function, or more structural methods of assessment, such as carotid IMT, MRI that you will hear about, and CT that you just heard about. I would like to start with this very old concept. You're all familiar with this, the Glagoff concept, about how the atherosclerosis evolves in an artery. And by the time we detect it by coronary angiography, it's already very, very advanced. So the first thing that happens is the artery remodels, it enlarges. So on coronary angiogram, it appears normal, although there is a lot of plaque within the wall. And it's only in very advanced stages that you would actually start seeing luminal narrowing. In the same analogy, you could really use this to study large vessels, such as carotid arteries, as well as the smaller arteries that are responsible, for example, for hypertension. So that these arteries are composed of, as you know, intima, media, and adventitia. And as atherosclerosis evolves, the first change that occurs is that you start getting endothelial dysfunction. The tunica intima thickens. The tunica media also thickens, particularly in patients with hypertension. And in fact, in patients with hypertension, the artery does undergo remodeling. It actually dilates. And then in the later stages, you start getting these early plaque formation and later on kind of stenotic kind of plaques. And if we are able to measure this very early change by a sensitive enough method that can give us an estimate of this intima thickness, then we would be able to pick up this disease very early on. And one such technique is carotid ultrasound. Now, we are fortunate that atherosclerosis in the carotid artery actually develops in relatively defined area, about 3 centimeters bulb and its contiguous areas below the bulb, which is a distal common carotid, and above the bulb, which is the internal carotid artery. So this 3 centimeters is really the target of our intervention or our evaluation when we do carotid ultrasound for IMT. This is an image of a carotid IMT of a normal person. You can see the lumen. This is the far wall. Now you will hear the terms near wall and far wall. Near wall is the wall which is near the skin or the transducer. Far wall is the one that is opposite. And what ultrasound does is, by measuring the time it takes for the ultrasound pulse to strike a boundary, this is a clear boundary between the very, very echolucent lumen and an echo-dense intima. You measure that time, and then you compare that to the time it takes for the pulse to come back from the media adventitia boundary. Now, ideally, we would like to measure the interval between intima and media, but the pulse duration of ultrasound is a limitation and does not really allow us to measure that intima alone accurately, which is why we combine intima and media assessment when we talk about IMT. This is what it would look like if you were to kind of take an M mode and a magnification. You can see the lumen. There is the intima. Here is the media, and here is the adventitia. And what we are measuring is the interval from here to here, the distance. These movies won't play because I couldn't find those movies, but kind of suffice it to say this is a normal person, a normal patient, a person in age 45, male. This is a woman age 48 who has very high HDL cholesterol. Actually, her lipid profile is excellent. She's a non-smoker. She's African American. And you can see that in a normal individual, you can actually barely even see the wall of the artery. You know, this kind of little white line, this is the intima. You can actually barely see it in the near wall. Whereas in this person, the thing is thickened throughout the common carotid as well as extending onto the bulb. If you kind of go a stage further, so these are the 2 examples I just showed you. The extension of the disease now will be formation of plaque. This is a 34-year-old man who's classified as very low Framingham risk. Look at his carotid IMT, very normal, but he has a plaque in the bulb. Another patient who not only has thickened IMT but multiple plaques protruding into the lumen. So these are the different stages of disease that we can pick up by carotid ultrasound, and the challenge becomes to measure these intima media accurately, because these measurements are several tenths of millimeters, and therefore there are several methods now available where you actually automatically etch detect these boundaries, and the computer draws multiple perpendicular lines over a distance, and that really enhances our accuracy of measurement, something that we did not have available before. And there are several commercially available systems out there that are actually able to do this with very minimal time. These are the studies. Now, we are kind of caught up with risk factors. So is there an association of IMT and plaque with risk factors? Yes, there are multiple studies done with several thousand patients. These are the age group that have been studied. This is the mean IMT. And these are the individual risk factors that these studies found correlate with either the plaque or the IMT or both. And you can see these are all the risk factors that we currently are aware of as being predictors of cardiovascular disease to some extent. There are several risk factors that have been studied in terms of their association with IMT. The list is really very exhaustive, but the ones that are highlighted red are the ones that have been found to be associated with intima media thickness. And you can see these are lipids, insulin, gene polymorphism, homocysteine, infection, and several other factors, including psychological and social. What about association of IMT with risk factors in childhood? This is the Bogalusa heart study in patients between 24 to 43 years of age, which are kind of relatively young cohort compared to other studies that have been done in IMT. And the chances of somebody belonging to the somebody having the highest IMT quartile, the chances of them having 3 or more risk factors is much higher than somebody belonging to the lowest quartile of IMT. So even in this young population, there is a relationship of risk factors with intima media thickness. This is a study showing the association of intima media thickness with the load of risk factors that you're exposed to during your childhood and young adulthood. So in this study, the intima media thickness in adulthood really represented the amount of LDL cholesterol that these adults were exposed to in their childhood as well as in their young adulthood. These patients had multiple lipid profile assessment during their transition from childhood to adulthood. So it is a very useful biomarker to look at even in children. Another study in children with high risk, this is the control group, diabetic kids. These are about 11 years or so. These are kids with hypercholesterolemia, and you can see compared to the control group, the kids at risk have much higher carotid intima media thickness, but even more than that, they have much thicker abdominal intima media thickness, and this abdominal IMT was not measured by any invasive means, just by ultrasound of the abdomen, which, as you know, in children is easier to evaluate than in adults. Now, if you were to look at the progression of IMT increases with age. And this is the study from Holland, which is actually a cross-sectional study when they looked at 500 odd patients with familial hypercholesterolemia and 500 normal controls, and then came up with these regression lines of the progression of IMT with age. So in a normal population, the IMT of 0.8 millimeter is roughly reached at 8th decade of life. Roughly, you could say 0.1 millimeter per decade. Whereas in patients with hypercholesterolemia, the same IMT is reached at age 40. And we know that this is about the time when these people start getting clinical manifestation of atherosclerosis. So there is enhanced progression of IMT in patients with risk factors. This is the AXA study from France, which shows the normal measurement, normal values of IMT in a healthy cohort. You would notice that, as mentioned before, IMT is increasing with age, and it is higher in general in men than it is in women. And if you notice, these bar lines really represent the 25th centile and the 75th centile. You can see the very little difference between a 25th to a 75th centile. So for a 30-year-old, 0.39 millimeter is 25th centile, and 0.48 millimeter is 75th centile, which is why the technique requires so much accuracy so that you do not over or underestimate disease in individuals. This is the largest study we have to date, which is a population-based study that was conducted in the United States in about 13,000 odd patients, aged between 45 and 65 years. So this is like the middle-aged cohort. And this shows the 75th centile of IMT in this population. And you can see that roughly the numbers are kind of, generally the values are less than 1 millimeter, even in later decades of life. So at 65 years, these are the values in black women, black men, and then corresponding values in white men and white women. So IMT is increasing with age. It's higher in men than it is in women. And roughly speaking, IMT of 1 millimeter is reached in later decades of life. And this is the 75th centile, which probably we think now is already kind of abnormal, and we should really be aiming for 50th centile of IMT or below. IMT reflects atherosclerosis burden in your body. This is the same study, the ERIC data, which looked at the prevalence of cardiovascular disease with increasing quartiles of IMT. So you can see that patients who had the thickest IMT had the highest prevalence of cardiovascular disease, and if you added all these together, the curve really kind of diverges in patients who have the thickest IMT. So it reflects prevalent cardiovascular disease, and for a given level of IMT, the prevalence of cardiovascular burden varies with the race. So this is a study in Canada, kind of very few studies you would find of IMT conducted in Asians, particularly the Indian subcontinent, and you would see that for a given level of IMT, this is the highest quartile in this population, patients with Indian, South Asian backgrounds had much higher prevalence of cardiovascular disease than Europeans or Chinese. So when we look at IMT measurements, we have to really take that into consideration. Another study showing that as your coronary disease progresses, your intima media thickness goes up. Again, association of IMT with disease prevalence, another association. As your IMT is progressing, the number of coronary vessels that you would detect on angiography increases, but there is a significant overlap, if you notice, in this particular study. Which is what brings me to this distinction between intima media and plaque. There's a lot of confusion about, is IMT good or is IMT not good? Because some studies come up with a negative conclusion, some studies come up with a very positive conclusion. And the reason is the different types of methodologies that have been used in different studies, besides all the other problems, the type of population and so on. But a lot of it is to do with methodology. There are some studies that have only evaluated common carotid artery and completely ignored the bulb and the internal carotid artery. And then in the common carotid, there are different studies that have looked at far wall, some have looked at near wall, some have looked at both. And so that's why we have such differing results. But essentially, when you're looking at carotid, you have to look at the entire spectrum of disease and not just confine yourself to the vessel wall. In fact, if you're ignoring plaque, you're ignoring a more advanced stage of atherosclerosis. So there is actually no consensus currently in the United States about what is a plaque. But there is a European consensus, it's called the Mannheim Consensus, which was recently published, which calls plaque anything which is 1.5 millimeter or more in thickness, starting from the adventitia media border to the lumen intima border. It's kind of a good measurement or good number to have for people to kind of collectively kind of identify their methodology, and you can see the clear distinction. IMT is a double line pattern. Plaque is a focal intrusion into the lumen, which looks very different to the neighboring normal or abnormal IMT. These are the studies that have looked at the prognostic utility of carotid ultrasound in predicting incident cardiovascular disease, both myocardial infarction, stroke, peripheral vascular disease, and cardiovascular death. I'm sorry about the slide, but this is the KIHD study, the ERIC study, the Rotterdam study, and the cardiovascular health study. These studies generally this is the study we talked about, 45 to 65 years. This is the corresponding study in older population, 65 years and above. And you can see the predictive value of IMT. Now, some of them have classified IMT and plaque separately. As I mentioned, some of them have not. So again, the definition, generally the cutoff of 1 centimeter kind of is what they have used to predict risk, at which the risk increases incrementally. So in this study, plaque increased the risk 4-fold. In this particular study, IMT of greater than 1 increased the risk 2-fold. And then if you looked at non-stenotic plaque, 3-fold, stenotic plaque 6-fold, and so on. And kind of similar results in all these studies. So IMT 1 millimeter increases risk. Non-stenotic plaque increases risk tremendously, and stenotic plaque, we all know from NASCET studies and other studies, increases risk significantly. So this is a continuum, if you will, and this is about the cutoff that we chose in our definition of what we call abnormal in the cutoff that we are going to use in the SHAPE recommendations for what is considered a very high risk intima media thickness, roughly around 1 millimeter, although there are a lot of caveats to this, as you know, age dependency and so on. If you look at age and race adjusted absolute risk of a given value of IMT in a man or a woman, so if a man or a woman has an IMT of more than 1 millimeter, the risk for heart disease, I think I burnt this laser, increases incrementally as your value goes up. But the amount of risk, the absolute risk, is small. So you have to keep that into consideration. We are not talking about plaque here, though. We're just talking about thickened IMT. Just like a slide that Dr. Fuster showed earlier on about the discriminative value of MRI in patients who had coronary artery disease events versus those who did not, when LDL did not really separate them out. Same kind of data with CIMT and LDL cholesterol. From ERIC's study, you can see the nice separation that CIMT provides between the lowest and the highest tertiles as compared to the LDL cholesterol, which really does not have any distinguishing value. This is a study from Europe, again shows the incremental risk thickening, which is defined as 2-fold, non-stenotic plaque 4-fold, stenotic plaque about 6-fold. So if you remember these numbers, these are kind of generally hold up in multiple studies. Another study, Rotterdam, you kind of have seen these kind of bar plots, which looked at the association or the incremental value of atherosclerosis detection in different parts of the body. So they did carotid IMT, carotid plaques, ankle brachial index, and an abdominal calcification by a plain X-ray, and found that as the amount of atherosclerosis progresses in an individual, the amount of risk increases. So they were proposing that these factors, these cumulative atherosclerotic, thank you. Great. So for example, if you look at carotid plaque and IMT, if somebody has both prevalence of carotid plaques as well as increased IMT, the risk increases tremendously, and it's actually highest compared to any other plot that you would see, which is why it is so important to not only just focus on intima media of the wall, but also look at plaques. This is the data from the community cardiovascular health study, which I mentioned in elderly above 65. People say, well, 65 years of age and over, there's no need to screen them. We just look at their risk factors and treat them. But even in this cohort, they found who had a very high prevalence of risk factors, but who had not had an event yet, there was a discriminating value of IMT in predicting future cardiovascular events, so that patients who were in the in the highest quintile had much higher disease events compared to the elderly patients who were in the lowest quintile. This is another study from Italy, who not only looked at carotid IMT and plaque, but also femoral IMT and plaque. And this is another area that, the more you look, the more you're going to find disease, the more sensitive your method is going to be, because there are about 20% of individuals who would have abnormality in femoral artery, either in the IMT or plaque, that you would miss if you just did carotid ultrasound, as they found in this particular study. So if you become more comprehensive and look at both femoral and carotid, they classified their disease incrementally, again, as normal, granularity or thickened IMT, and the definition here is 1 millimeter as the cutoff, non-stenotic plaque and stenotic plaque. And you can see this is in about 2,000 individuals. All the events that occurred over about a 6-year follow-up occurred in patients who had class 2 to class 4 carotid artery morphology. And all the deaths that occurred over follow-up were in patients who had class 3 and class 4 morphology. So incremental disease, incremental risk. This is a study in patients with a stable angina. What about the predictive role of IMT in patients who already have pre-existing disease? They found that when you adjust for risk factors, all the risk factors that these patients had, including presence of previous cardiovascular disease, the carotid IMT fell out in predicting future MI or stroke, as well as future revascularization, although non-adjusted, it had a significant predictive value. But when you added the presence of either carotid or femoral plaques, even after adjusting for all these risk factors, the presence of plaque in either of these two territories really was able to identify those patients who were going to have events. This is the data from Howard Hodis from Los Angeles in patients who have already undergone bypass surgery. In this particular study, about 140 men who were randomized to treatment with lipid lowering. He looked at the progression of IMT, and even in this small cohort of 140 patients, he was able to identify that patients who progress the most in a year, so if you have a progression of about 0.03 millimeter in a year, your chances of having future myocardial infarction is much higher than somebody who progresses 0.01 millimeter or more. In fact, the risk events were 5% in this one and about 25% in the highest progressive group, although this technique is not sensitive enough yet to look for progression in individual disease. And we are not using it for that particular purpose in our lab, but when you look at it as a group, then it is sensitive enough. This is a very recent paper from P.J. Taboul from France, who has done a lot of work with IMT, has got his own software about automatically edge detecting it, who looked at the predictive value of these various, the IMT and plaque over and above the Framingham risk score in patients who presented with stroke. This is actually a cross-sectional study, so about 500 patients with stroke, 500 normal controls. He measured their risk factors, he measured their IMT and plaque, and found that when you put them into a multivariate model, each one of them actually predicted the occurrence of stroke. So the Framingham risk score has utility. IMT incrementally increases it. Plaque increases it even further. Mort asked me to show this slide, which is why I'm showing this to you. This kind of seems a little unrelated. But anyway, when we are talking about the screening for cardiovascular disease, we talked about carotid, we talked about femoral, we talked about abdominal ultrasound in children. But here it is, the utility of routine screening for abdominal aortic aneurysm in elderly patients. This is a meta-analysis of about 62,000 patients who were randomized to either receiving abdominal ultrasound screening versus not. And obviously those patients who were found to have aneurysms were then treated surgically, and they looked at the mortality benefit of actually screening patients in different, according to gender, according to age, and so on. And they found that screening patients definitely decreases risk of having deaths from aortic aneurysm complications. This is not any complication. This is just related to aortic aneurysm. But when you look at the cost-benefit ratio, the abdominal aortic aneurysm screening is recommended for men between 65 and 75 years of age who either currently smoke or had ever smoked in their lifetime. The value of routine screening is the highest in this particular population. There are recommendations now from writing groups. This is the text from Circulation of 2000 from AHA Task Force, which talks about these 5 published studies. I mentioned them to you, the ERIC, the CHS, and so on, that found that carotid IMT is a viable predictor of the presence of carotid atherosclerosis and its clinical sequelae. This is the prevalent and the incident disease. Thus, carotid IMT, defined by non-invasive B-mode ultrasound, has been shown to be an independent risk factor for CHD events and stroke. This is the text from that particular guideline. In asymptomatic persons greater than 45 years old, carefully performed carotid ultrasound examination with IMT measurement can add incremental information to traditional risk factor assessment. And in experienced laboratories, the test can now be considered for further clarification of CHD risk assessment at the request of a physician, which is exactly what we are trying to do at our institution. We've been doing so over the last 2 years or so, and I'll show you some examples. Both of these examples, this actually is a patient that was referred to me by Dr. Shah, a 53-year-old male, Caucasian. This is the total cholesterol, the HDL cholesterol, LDL, total triglycerides, no diabetes, no hypertension. The Framingham risk came at 11%. That's intermediate. When we did the carotid ultrasound, you can see the intima here, the media, the black layer, and the adventitia. There was no plaque in this patient on either side, and this is the worst IMT that I found. And if I extrapolated this to ERIC data, he actually fell below 50th centile of risk, 50th centile of IMT. So here is a patient who has risk, and undoubtedly you will treat him, but this is kind of a reassuring thing to see that this patient, despite exposure to the risk factors, does not have evidence of atherosclerosis in at least the carotid bed. This is another patient, a 61-year-old female, whose total cholesterol is 216, HDL is 50, LDL is 143, triglycerides are 239, which doesn't even count in our Framingham risk assessment. She's 162 pounds, 5 foot 2 inches, a little overweight. She's postmenopausal and she's depressed. And obviously we don't screen for depression in our population, but I gave her this questionnaire that I like to give to patients called the Zoom questionnaire, which I find helpful. But in any case, if you looked at the Framingham risk score, it's 6%. You know, there is such a high bar for women to ever meet the treatment goal in Framingham risk that, you know, none of your women will ever get to that point, that holy number of 10% or above. This is amazing. But anyway, when you look at the ultrasound of this person, this is kind of from both sides. This is the short axis view. You can already see a plaque layering in this area. This is the bulb. You can see the plaque here. And these are different. This is the internal carotid artery. This is the far wall. You can see a plaque here. These are different angles that we use to image. And so obviously this patient has got more subclinical disease than would be evident if you were to just look at her Framingham classification. Just like Dr. Budoff showed you the picture of a heart with calcified vessels and how patients' compliance improved with that, imagine if you were to give this picture to your patient. So this is a patient who has thickened IMT on the right side, and has got these multiple plaques on the left side, and her Framingham risk score was also very low. It was less than 10%. And there have been studies done by Dr. Jacques Barth in young adults showing that when you do their carotid ultrasound and you actually give them the image to put on the refrigerator, the compliance of these individuals increases tremendously. And I think this is a very helpful. I like to do that in our patients sometimes. Just a little word about neovascularization. You heard this from Dr. Fuster. There is actually some preliminary work being done about plaque neovascularization. I'm sorry these pictures won't play, but these are the slides I got courtesy of GE Ultrasound. I think these are done from Dr. Feinstein's lab, which shows a plaque here, a plaque here. This plaque has got much more contrast in it. I'm sorry, again, it will not play, but you would see the optisone bubble kind of running around inside the plaque from outside in this image. Again, the same article from Dr. Grundy. He goes on to say that there are no acceptable published charts for age-related distribution for either coronary calcium scores or carotid intima media thickness, and until these charts become available, adjustment of age scores according to measured plaque burden will not be possible, and measurement made in different laboratories must correlate consistently with those with age-related distribution of plaque burden. And this is the limitation that we have currently about when you're trying to use this particular tool in your clinical practice. There are such differing methodologies, there are such differing cutoffs and values that it's kind of becomes very difficult to know how to actually risk stratify your patient. And so we have to take, when we look at these data, we have to look at methodological criteria, as I mentioned. You have to look at what you're going to image. Is it CCA? Is it bulb? Is it ICA? Are you going to image both sides? Are you going to also include femoral? Are you going to look at intima media? Are you looking at plaque? Are you looking at near wall, far wall, maximum, minimum, or mean max? I mean, this just goes on and on and on. And so we have actually kind of come up with our own method that I will not like to go into the details of, but these are the goals and challenges that we face, which is to confidently establish an independent role in cardiovascular risk prediction over and above that with clinical risk, including C-reactive protein, and to demonstrate that by identifying an individual at high risk, we can actually impact their course. Otherwise, this is no good. Comparing the individual modalities such as MRI and CT, and then get some more data about ethnic minorities and women. Thank you.